Good afternoon and welcome everyone. My name is Robin Buxbaum. I am the Strategic Partnerships Coordinator here at ACHA. This is our 6th ACHA COVID-19 webinar discussion. With the release of the reopening guidelines, the ACHA COVID-19 Task Force has decided it would be useful to return to weekly webinars for a more detailed discussion on several key topics of interest. Today we are just giving a general overview of the guidelines. But next week, we will further explore the topic of housing, and the following week, we will be discussing contact tracing. If you've missed any of our past webinars, recordings are available on the ACHA YouTube channel. As another reminder for all the latest updates, continue to check the ACHA COVID-19 website. At any time today, feel free to type a question into the questions pane on the right side of your screen. While we have allotted a fair amount of time at the end for Q&A, we may not get to all questions today. We do review that list after each webinar and have been using those questions to guide us in our work. One last item, those registered will receive a link to a recording of today's presentation, so feel free to share that. But as I mentioned, it will also be posted on the ACHA YouTube channel. With that said, let's get going. I'm pleased to introduce our 5 speakers today, all of whom are members of the ACHA COVID-19 Task Force. Dr. Jean Shin currently serves as an Associate Clinical Professor of Medicine at Augusta University, University of Georgia Medical Partnership. Prior to that, she served as the Executive Director of the University Health Center at University of Georgia. She is also the esteemed Chair of the ACHA COVID-19 Task Force. Dr. Michael Deichen is the Associate Vice President of the University of Central Florida Student Health Services, where he has been for over 17 years, and where he oversees the health of almost 70,000 students. Dr. Deichen is active in ACHA, serving on the current COVID-19 Task Force, the Emerging Public Health Threats Task Force, and the Foundation's Vaccine Survey Project. Catherine Ebelke is a PA certified in travel health with over 20 years of college health experience. She is the chair of the ACHA Travel Health Coalition and a founding member of the ISTM Student Travel Abroad Interest Group. She has been the coordinator of the International Travel Clinic at Montana State University Student Health Service since moving to Bozeman from Kathmandu, where she's worked as a PA at the CWEC Clinic. Dr. Michael Huey is the former Assistant Vice President and Executive Director of Emory University Student Health Services. He recently retired from serving as an Associate Professor of Family and Preventive Medicine at the Emory University School of Medicine, and is also a past president of ACHA, an ACHA Fellow, and the 2019 recipient of the ACHA Lifetime Achievement Award. Last but definitely not least, Dr. Sarah Van Orman is a clinical professor in the Keck School of Medicine and the Chief Health Officer of Student Health at the University of Southern California. Board certified in internal medicine and pediatrics, she is a past president of ACHA and has over 20 years of experience as a college health physician and campus chief health officer. So first of all, welcome to everyone and thank you for joining us. I am going to turn it over now to Dr. Chin to kick us off.
Thank you so much, Robin. And if we get to the first slide, you can see by now those first guidelines we developed preparing for COVID-19 is just a faint and distant memory, and those were released really only 2 months ago. I was very lucky to convince 7 of those original writers to come back and write this second in the series. And since there were 7 of us, 1 of us needed to create a cohesive document from those pieces, so it didn't look like this camel rather than the horse we intended. So if you lay our reopening guidelines side by side to the first guidelines we wrote, you'll see that the format and the broad topics are the same, just expanded. We wanted this to be a true sequel. So you can see this timeline too. We approached with that same overall concept that one size does not fit all. Each college and university has to look at these guidelines through their own lens and use what makes sense to them. We are going to be following up soon with a section on health disparities and the effects of COVID-19 on HBCUs, MSIs, and our students and faculty of color. We felt this was such an important topic, it needed its own standalone document. And you can also see on that last line, we have other potential topics in our series. So if you all have other things you'd like us to write about, please email the COVID-19 Task Force. We are happy to look at them. And it is now my deepest privilege to turn this over to my friend and colleague, Dr. Sarah Van Orman, to talk about student health services preparation and containment and surveillance.
Good afternoon. Thank you, Dr. Chen. It is a pleasure to be with you today. Containment and surveillance is the cornerstone of any conversations about reopening our campuses. We know that we will need to have robust systems in place to detect the emergence and spread of infection. Institutions will have different approaches to meeting these goals, and many times this will need to be in close collaboration with public health and local health organizations. ACHA will later be presenting a webinar more specific to contact tracing, but there are several central capabilities that will need to be developed. First, it will be important to ensure that testing is available to all members of the community who develop symptoms of COVID-19. When cases are identified and exposed persons subsequently found, it's important that systems are in place to ensure those ill individuals can be isolated and the exposed persons can be quarantined. Providing for isolation and quarantine will go beyond just providing a housing spot. Careful case management to ensure our students' physical, emotional, basic needs are met while they're isolated and quarantined should all be part of the reopening plans. Finally, areas of emerging research include how we will detect asymptomatic individuals. Many institutions and researchers are developing strategies around viral surveillance, and this will be an important part of many of our reopening plans. Finally, I'd like to make a note about antibody or serologic testing. Currently, the research does not support this as being deployed widespread. However, we need to continue to watch the emerging evidence on this, and if and when we can determine serologic testing becomes a marker of immunity, it may become a future important part of our strategies. Next slide. As we think about preparations within the student health service itself, there are several key tasks for us to be working on right now. First and foremost are those partnerships. The partnerships with local health agencies, with other health systems, and public health are the cornerstones of ensuring that we're able to provide all the different services we need to. Campuses should begin now anticipating their needs for personal protective equipment and determining if and when they will be able to procure it. Good tools exist through the CDC of estimating how many masks, how many gowns you might need for various activities such as screening, vaccination, and treatment. On the next slide, we'll talk about the specifics, but delivery of patient care in the COVID era will look different, and we need to make sure that we have the policies and procedures in place, the staff training, and the facilities to support it. Finally, one of the most important roles that the medical leadership at Student Health Services provide is that advising our campus leadership, ensuring that campus level policies, communications, and education are grounded in evidence-informed, sound public health practice. Next slide. So what are some of the specifics of patient care that we might want to be considering at this time? Telemedicine should very much remain one of the primary modes of care delivery when it's possible. We know it will be preferred for individuals who may have COVID-related respiratory symptoms. It's also critical for vulnerable populations, persons who may be higher risk of COVID-related complications in the event they acquire the infection. It's important that we are able to identify anyone who might have COVID-19 infection before they come into our facilities. And when we determine they need in-person care, that we have robust protocols in place to ensure that we are able to protect other patients and staff from infection. A careful modification and review of our facilities will be needed, whether that's creating physical distancing within the student health service, assessing the regular ongoing cleaning we need, and also making determinations about the cleaning needed in the event that we would have a suspected case. Working closely with your local facilities, environmental health and safety to assess air exchange and other aspects of your facilities are tasks that can be taken on now. Care will look different in the post-COVID world, and we want to make sure our campus community is well prepared and understands the new processes that may be in place, and that we continually assess satisfaction with them. We want to support and train our staff members, in particular thinking about how we handle high-risk employees, as well as in the event of the inevitable employee exposures. I know many of us right now are looking at our financial models to understand what this will mean over the coming months. And finally, I can't stress the importance of thinking about how we can significantly increase the percentage of our populations who receive the influenza vaccine this year. It's imperative that we reduce the burden of influenza, as it's likely we will have influenza, the yearly influenza cases circulating at the same time as COVID, and the ability to manage those febrile respiratory illnesses will pose a challenge to us all. Next slide. Changing a bit, much has been written about this, but we know that throughout our campus, there are basic things that need to be considered in terms of our facilities. Physical distancing will remain important, whether that's for our workers or through our students. Things such as developing maximum occupancies for areas and making physical modifications can happen now. Enhanced surface cleaning continue to play a really important role, as does the use of face coverings and PPE when indicated. With ongoing shortages in these areas, estimating campus needs and developing strategies to procure those before there are more employees on campus remains critical. Simple strategies such as signage, perhaps when paired with other public information campaigns, remind individuals to comply with campus rules, as well as supporting hand sanitation and implementing no-touch options whenever possible. With that, I'd like to turn it over now to Dr. Michael Deichen, who will talk with us about mental health services.
Thank you, Sarah. The COVID-19 pandemic represents a significant infectious disease threat to our campus communities, but possibly more significant to that is the threat that COVID-19 presents from a mental health standpoint. Our students are being bombarded by negative media. They're being asked to physically distance themselves, which is leading to increased isolation and disruptions of their normal routine. It's not surprising that we're facing ever increasing demands for mental health care. Next slide. A 2018 tracking poll indicated that 2 to 3% of Americans engaged in telehealth. In April of this year, that poll demonstrated that 23% of adults have reported using telehealth for outpatient care. That's just incredible. There's been this enormous increase in telehealth services. Telemental health is a subset of telehealth and likewise has expanded significantly. Many of our clinics are now closed to in-person care, and telemental health is our primary means of providing mental health services. We anticipate the pendulum is going to swing. It swung very strongly to telemental health, and it's going to swing back to in-person care. And we don't know how far back, but it's very possible that it'll never swing back as far as it once was. And we're going to find a balance between our in-person care and telemental health care services that's different from before COVID. At UCF, we have a committee, our COVID Patient Care Committee, which is deciding how to gradually phase back to in-person care. And I think it's important to get the opinions from the persons that are providing the care so as to keep things as centered as possible on safety and to best respond to their personal concerns and issues. So we're looking at a phased in approach, and that's what's being done throughout much of the country. Next slide. The first phase of telemental health movement to in-person cases should prioritize what's needed most on an in-person basis. Services such as crisis counseling, persons that would otherwise be unable to access telemental health, or if the mental health provider feels that an individual would be better served by an in-person visit, we need to give consideration to that. They have a close working relationship with their clients and best know when that could be advantageous. Next slide. If we're going to have a return to in-person visits, we need to make sure to establish policy and procedure for those visits. It's important to clearly define who may see someone in person. What kinds of clients will they be? It's important to screen for COVID symptoms both prior to the visit and at the point of visit. So when they call to make an appointment, to have screening questions that ask the CDC COVID symptoms if they're present, and to repeat those at the point of presenting to the counseling center or mental health institution. It's important that all patients and staff wear a facial covering, that there be ample opportunities for hand hygiene, there be adequate waiting room spacing, and environmental protections be placed. Environmental protections include things like sneeze guards or plexiglass that prohibits large droplets from being exposed to our receptionists, appointments people, and others. Next slide. So we have to look for innovative solutions to some degree. And this has evolved quite naturally as we've moved to telemental health. There now are such things as online workshops. Many mental health programs are using drop-in online counseling, let's talk sessions. And there exists a variety of automated online therapy and mindfulness solutions. There are things such as Cognito and therapy assisted online that can be with a therapist or self-help. There are various online COVID-19 mental health resources that are provided by SAMHSA, JED Foundation. There are suicide hotlines. The NYC Well Digital Mental Health Resource Line is an excellent resource for various online mental health resources as well. Next slide. We have to consider our staff. This is a trying time. They care about their patients. They have concerns about their family and their own well-being. They might be facing financial hardship or physical health hardship. We need to make sure that employee assistance programs are open and available, and to provide staff debriefings on a regular basis. Give your staff an opportunity to talk about what's going on, what's bothering them, an opportunity to ventilate their own anxieties and find solutions. Also, this is a wonderful time to provide training and resources to reduce mental health concerns. Next slide. I now have the privilege to introduce Dr. Michael Huey.
Thank you, Mike. Campus preparation really is an important part of our phased reopening on our college campuses. And we want that preparation to be organized. We want it to be safety focused. And we would like to have it be informed by our medical and mental health and our public health staff on our campuses. And that's made it difficult, I know, for all of us in college health to completely stay in our lanes when it comes to COVID-19, because at its heart, COVID-19 is a healthcare and a public health crisis, and our campuses need input from healthcare and public health to deal with this crisis. In addition, as we were putting these guidelines together, it was important for the task force to work with our partners, both nationally and internationally, to look at these guidelines and help us to vet these guidelines. And as you move forward on your campus, I know that all of us understand that the engagement of our executive leadership at the very top of our colleges and universities is critical to this process being effective, and also the continuing oversight and coordination of the COVID-19 Planning and Response Committee that your campus has put together. Next slide. Next week's webinar is going to be on housing considerations, but we'll look and give an overview now about the housing section of the reopening guidelines. When our campuses are fully open, we may have thousands to even tens of thousands of students who are living and dining on our campuses. And it will be difficult in a situation where our campus and our community is still at full physical distancing to maintain that level of safety for our students in our standard housing settings. While we often will have some single rooms, many students are living in rooms with 2 or more individuals per housing space. Roommates from different parts of the country, different parts of the world, in places that are high prevalence for COVID-19 and in places that may have been low prevalence for COVID-19. We also know that our housing situations on our campus will have a differential effect on high-risk individuals in our student population and frankly in our staff and faculty population as well. So our campuses are going to need to answer a fundamental question, which is, in the first wave of bringing students back to our residence halls and to other on-campus housing and to full activities on our campus, is it appropriate for high-risk individuals to be part of that first wave? And how do you do that in a way that is both understanding of the needs of those individuals, but also the difficulties that we have when we have high-risk medical conditions? Next slide. Our campuses will need to be proactive in identifying appropriate residential spaces, either on the campus or in some cases, if we do not have extensive availability to free up residential spaces, looking at off-campus locations for isolation and quarantine of on-campus students. And I've put the word on campus in red here because it is not reasonable for us to expect that our colleges and universities can provide isolation and quarantine housing for students who live off campus. We also need to be sure that the availability of these spaces is able to anticipate and expand in the event of a surge of COVID-19. We need to be sure that we have appropriate PPE per CDC guidelines for our custodial staff so that when they are doing cleaning in standard housing, and more importantly, when they're doing cleaning in isolation and quarantine spaces, that they have the protection that they need. Our RAs really are our public health officers on the ground in residence life, and it will be important for them to be fully trained on public health measures and the signs and symptoms of COVID-19. And finally, we will want to look at on our campuses what sort of events and social activities are important as we move through a phased reopening. Which ones should we do? Which ones should we not do in situations where we may have ongoing needs for physical distancing? Next slide. Well, our dining areas in colleges and universities can often be very large spaces, and in a current non-COVID-19 situation, they can be large and chaotic. The tables and chairs can be very closely spaced, certainly not maintaining current recommendation in terms of physical spaces. And there are a large number of interpersonal interactions that take place in our dining areas. So if we are going to, in the early phases of reopening our campuses, be able to maintain appropriate physical distancing and other infection control and prevention measures, there will have to be some changes made. And it could be that we will need to limit the number of individuals in that facility at one time. That can be in a way that's currently being done in many of our supermarkets or our shopping areas, where people are let in numbers to maintain the maximum capacity of the building. Therefore, people have left, people can come in. But there also could be approaches that would include cohort dining, where you could allow members of the community to come in during set times when they are told that that is when they would be available to dine. It will be important to continue takeout meal options, and maybe in the very earliest stages, some of our campuses may choose to have a bag takeout service only for dining. And it will be important to look at food delivery to students who are in isolation and quarantine, and how that can be done in a way that both respects the needs of those students, both physical and emotional, and also provides protection to dining and residence-like staff. Next slide. Well, we all know that there's a high risk of transmission of infection in athletic settings, and we've dealt with this for years, those of us who are in sports medicine, because of frequent physical contact and aerosolization and fomites, water bottles, towels, etc. And that is certainly true for COVID-19. So it will be important that as there is a phased return to intercollegiate athletics, that department policies and procedures align with the institutional policies of your campus, but also with CDC and public health guidelines and requirements. It is a good idea to consider creating an ancillary team off of your main campus COVID-19 preparation and management team that looks specifically at athletics and is responsible for the creation of an action plan for the reinstitution of athletics. That team will need to look at the potential for COVID-19 transmission in each of the sports, and that risk of transmission is going to vary in individual versus team sports, in contact versus non-contact sports, and decisions may be made to do a phased return to participation based upon the potential risk of transmission in an individual sport. Next slide. Classically, pre-participation screening takes place in large group settings with athletes lined up and maybe hundreds of athletes screened in a single evening or 2 evenings. And it's almost certain that at least in the early stages of reopening of intercollegiate athletics, that there will need to be changes to pre-participation and screening of student athletes, including, if that athletic program isn't already doing so, getting health histories and exposure histories from those athletes in advance of their arrival on campus. Because our athletes have gone through extended periods of inactivity and not been under supervised exercise, it will be important for our healthcare teams and our strength and conditioning coaches and our sport coaches to be sure that they follow the recommendations for transition of activity and acclimatization to activity after inactive periods. We know that testing is going to be a part of the return to intercollegiate athletics, and as of the time of the publication of our guidelines, there were still extensive discussions going on about who to test, how often to test, and what tests to use as you decide about participation of given teams and given sports. You will also need to be looking at issues related to physical distancing in athletic areas such as team rooms, locker rooms, meeting rooms, etc. Next slide. Well, it will be important to have thought about the transportation, assessment, and testing of student athletes or staff who may have potentially become ill with COVID-19, and therefore an understanding of isolation and quarantine approaches for those students, if indeed those approaches are any different from other students on the campus. Our athletic trainers and our custodial staff will need to have training and access to appropriate PPE for cleaning of both clinical and non-clinical areas. Our teams will need to look carefully at travel considerations, and finally, be very important to look at training on infectious disease and on COVID-19 for our athletic staff and our student athletes. Next slide. Well, many of the guidelines for intercollegiate athletics apply to recreation services because club sports and intramurals on many or most of our campuses fall under the oversight of rec services, and thousands of students on campuses may participate in club and intramural sports and fitness classes. We want to remember that there are many positive effects of exercise on the immune system, on the chronic diseases that place people at higher risk for COVID-19, and on the psychological well-being of the exercising individual. Next slide. However, these positive effects of exercise will be balanced by looking at enhanced risk of transmission in some of our rec services, club sports, and intramural sports settings. You will want to align your recreation services policies and procedures and communications with those of the institution and the CDC and your public health departments. There will need to, once again, be infectious diseases education for recreational staff. Excuse me. And we're going to need to assess our sports for COVID-19 transmission. Next slide. In our rec services facilities, we will need to look at the maximum number of people that should be in a facility at one time. That could include access control or use by appointment. We will want to continue to offer, or if we are not already offering, starting virtual recreation classes, making sure once again that those people who were responsible for the cleaning and disinfection of common non-clinical spaces have access to PPE and training. Next slide. And finally, this is not the first time that our campuses have dealt with crises and emergencies and the need to effectively communicate in those situations. So we do have experience on college campuses in being sure that we are following the important steps in effective crisis communication. And those steps include unified content, making sure that our communications are appropriate in tone, are calm and confident and compassionate, and that they're timely and updated frequently. We will want to provide these communications through multiple platforms, and we'll need to be on top of adjusting and assessing these communications to be sure that they are both up to date and that they are effective. Next slide. Now we get to have Catherine Ebelke talk with us about international travel. Catherine.
Thank you so much, Mike. So international travel still exists, believe it or not. And at this time, though, and into the foreseeable future, there are restrictions from the U.S. State Department and CDC with advisories to avoid all non-essential travel globally. So while our current situation limits most of our urgent needs to address international travel issues at institutes of higher education or IHEs, it provides an excellent opportunity for preparation and groundwork in anticipation of the eventual resumption of international travel. So to that point, here very briefly are some considerations. These recommendations would apply to all students, faculty, and staff involved in IHE-related travel and will be unique to every institution. All of our information presented today, as well as international travel resources, will be available on our ACHA website. Next slide, please. Creating a standing international travel committee involving all key players is essential. This group will be responsible for developing well-informed, relevant policies around all aspects of international travel, which will be revised as indicated and will be enforceable. Appropriate group members will remain well-informed on relevant current international travel safety and health issues, which will be communicated as indicated in a timely manner. The group may involve representatives from Office of International Programs, Student Health, CAPS, Admin, Safety and Risk, Faculty Senate, General Counsel, Res Life, and others. Local health departments may become involved PRN and their input welcomed. A travel registry must be established and its use must be mandatory for all IHE-related travel. This is surprisingly uncommon at IHEs, and yet it is an essential tool in managing any travel-related challenges or emergencies. There must be efficient traveler tracking capabilities as well as reliable, effective bidirectional communication for the duration of travel. Next slide, please. Appropriate insurance coverage is essential. It must be mandatory and include adequate evacuation coverage. It's important, too, to confirm the absence of pandemic exclusions, which have been an issue in the last couple of months. Mandatory and robust pre-travel preparation is critical. Some elements to consider are listed here. If possible, making these available virtually is fantastic. Traveler familiarity with using communication tools, emergency contacts and responses, seeking aid while traveling, accessing insurance, destination health and safety issues is crucial. In all of this, we must pay attention to the basics. All international travel requirements must be clearly communicated to all affected parties well in advance of intended travel and must be enforceable. Next slide, please. In regard to returning and new internationally traveling students, faculty, and staff, including visiting scholars and researchers, the evolving situation is complex and changes daily in many realms. It is vitally important to involve your International Travel Committee in these matters. Clear communication to and from incoming persons is absolutely crucial and should be initiated as far in advance of anticipated arrival as possible. Current IHE, local, state, and territorial requirements must be clearly communicated and understood by all parties. Arrangements to be enacted upon arrival should be discussed. International and U.S. travel restrictions are unpredictable and could change at any time. Travel plans can easily be disrupted or canceled without warning. Flexibility for all parties is key. Mental and physical health issues, as well as academic and social concerns, are commonly encountered in IHE international travelers and should be considered, anticipated, and addressed as appropriate. And I would love to turn it back now to Dr. Jean Chin, our esteemed task force leader. Jean?
I'm going to use esteemed now in my CV anytime I write it. Thank you, Catherine. Before I start with before I start with health promotion, I want to give a shout out to Dr. David Anderson, who made significant contributions to this section in our guidelines and to this slide, by the way. So thank you, Dr. Anderson. Health promotion, one of my favorite divisions at the health center, has a broad portfolio, and it's so incredibly vital, particularly so during these times. As our traditional outward-facing entity, this is the group that students typically know. This is their opportunity. Health promotion has a grand opportunity now to showcase their value to the overall health of this campus through their expertise in assessment, environmental change strategy, social marketing, and social norming, in addition to everything else that they do, the trainings, the workshops, the health ed programs, the individual counseling they provide. Again, one of the broadest portfolios in all of college health. Highlights from these guidelines in a nutshell: with the educational and skill building activities, deliver as much content as possible online. If you have any in-person contacts, limit your attendees to 10, practice your physical distancing, use your face coverings. Start each single program with a brief instructional session on sound public health practices. In your messaging, use a variety of methods, venues, and outlets. You need to reinforce those sound public health practices and reach your target audiences. You know who they are on your campuses. Consider who the ultimate and the intermediary audiences are. And in assessment and evaluation, by the way, this is their wheelhouse. Gather info and insights to help guide your health and well-being initiatives. Assess your students, your faculty, and your staff needs and issues. And for everything that you do, consult with your campus or your local public health experts and collaborate. These are the greatest collaborators in the health center. Collaborate with campus offices to plan and guide messaging and healthy campus initiatives. Next slide, Robin. And now for the take-homes. This is my favorite part, the take-homes. Maintain your incident command structure with your well-defined chain of command, your discrete roles, your responsibilities, and your backups. Drill your tabletop plans. Inevitably, there's going to be a crack in your plan. So what are you going to do now? You have to play out all your scenarios that you possibly can. If you can do nothing else on your campus, if you have zero resources, you can do this. You can educate. You can educate on your non-pharmacologic interventions, your physical distancing, your hand hygiene, your cough and sneeze etiquette. All of our public health experts agree we need testing, isolation, quarantine, and contact tracing to decrease the risk of transmission. We know a vaccine and treatments are well down the road. Dr. Fauci said a bridge too far. And yet we have to start planning now for our flu vaccinations and our potential COVID vaccine. Secure your supplies now because everybody else is going to be trying to do it. Our vulnerable populations, including those medically susceptible, older than 65, must be protected. And policies on when and how to bring them back to campus must be developed in conjunction with your health experts. Reach out to others. The beauty of ACHA, and more than any other organization I have ever been involved with, we help each other. We help each other. If there's a call out, we help each other. So next slide, Robin, our final slide. This is the small army it took to move these guidelines out in 2.5 weeks. And it reinforces my last statement that we have always been an organization of helping hands. So I appreciate this COVID-19 task force and all the helping hands it has provided and all of our partners that you see listed here. And now I'm turning it back over to Robin.
Thank you, Dr. Chin, and thank you to everyone. Thanks for your presentations. We have quite a few questions. I'm going to try and get to as many as possible. We got a lot of questions about housing, and so I'm going to ask a couple of them, but I want to remind everybody that we are going to focus on housing next week. So Dr. Huey, I'm going to actually throw this one out to you. There are quite a few questions about how to figure out enough rooms for isolation and quarantine, and then also talking about the private bathrooms and the community bathrooms. Can you dig into that a little bit?
Well, they're both difficult areas. And as of this time, none of the organizations with which we have been working, and that would include CDC and the Housing Officer Organization, have specifically come up with a formula for determining the correct number of isolation and quarantine spaces. It is almost certainly going to involve the help of the members of your planning team that have public health experience, and looking at the incidence and prevalence of COVID-19 in your community and trying to do some calculations based upon the number of students that you have living in on-campus housing. The issue about single rooms and single bathrooms is also very difficult, and it may not be feasible on many of our campuses to have a setup where people could have access to a single bathroom, or certainly in a situation where you have a full cadre of students on your campus, that they would have access to single rooms. And so many of the physical distancing recommendations would be difficult in a situation where those campuses are fully populated. If you are going to have students using a shared bathroom, then you're going to want to look at other kinds of measures that could be protective in that setting. And while COVID-19 does have some GI symptoms and GI transmission, it is primarily a respiratory illness. And so we know that enhanced cleaning will be necessary, and it may very well be that the number of people doing that cleaning may need to increase on a given campus. It may also be possible for you to cohort the use of that bathroom, where certain areas of the floor use the bathroom for 30 minutes, and then there is a cleaning session, and then the next area of the floor has access to showers, etc., for a period of time. And obviously, that's not ideal, and obviously there are people that need to use restroom facilities urgently. The approach will need to be to reach the best possible compromise that you can, given the setup, your housing inventory, and your on-campus numbers of students who are currently housed.
Thank you. Just one more housing question. There are a few questions here about creating like a bubble or a family unit where students, either in off-campus apartments or even suite mates, they're considered sort of a unit. Do you have any thoughts about this, doing something like this?
Well, if you have a living situation, which many of our students do, where there are multiple members of the campus community living in a single space, either in on-campus housing in suites, or in sorority or fraternity housing, or in off-campus settings, then in a situation where there is an individual who needs to be pulled out of that space for isolation, then it certainly, I think, could make sense, and you would want to be sure that you're seeking the recommendation of your public health experts. But to cohort that group that lives in that apartment or that living space in terms of the quarantine that is necessary. We also know that a lot of our intercollegiate athletes live together, for example, so we may have multiple members of a single team who are in a single living space, and so dealing with them in a way that the public health department might deal with the family unit could make sense.
Okay, thank you. We're going to move on to some testing. And this is for Dr. Van Orman. I'm going to throw this one out to you. There are quite a few questions about mass testing, but before we get to that, could you maybe discuss in detail some of the differences between the testing, the point of care testing, the antigen, the PCR, the antibodies, and specifically the IgM and IgG testing?
Yeah, so I'll speak to this just in general terms. So when we think about testing, we're really talking about two things. We're talking about detection of the virus or DNA or sort of genetic remnants of the virus through the PCR testing. That testing is widely available right now. It's very much indicated for individuals who have symptoms consistent with COVID-19, and it also is indicated in many cases for people that are exposed to someone with COVID-19. And what we're also starting to see right now across many of our communities is use of the viral testing to detect asymptomatic infection. So in individuals without symptoms. We think that those are very good tests in terms of their specificity. We know that there are limitations to their sensitivity, which means that tests that are positive generally are consistent with infection, although in some cases there may be prolonged detection of the virus even past the point of infectiousness. But we do know there's limitations to the sensitivity, meaning that someone can actually be infected and the test may not pick it up. So viral testing right now is widely available. There are many tests available. If you follow the news on this, and I know people are asking a lot of questions about what the right test to use is. There are some what we call point of care tests being developed. There are also many tests that are available that may not be FDA approved. But what I encourage schools to do is to, if they have a lab themselves, to work with their lab managers, if not, to work with their local health system, their reference lab, or their health department in terms of assessing an FDA approved viral test that they would want to be using to manage individuals that are sick or exposed on their campuses. The other piece of that, and I know we'll have another webinar about this, is we do know that there are many people that are looking at how we should be testing large numbers of people who are asymptomatic, doing what might be thought of as surveillance testing. That's a very complex area. I think many people are looking about what the best ways to do that are, and I think more will be emerging in the coming days to weeks. The second piece of the question has to do with antibody testing. Antibody testing detect the presence of antibodies to the virus and are a marker of either current or past infection. The evidence on antibody testing is evolving rapidly, and what we know about antibody testing right now is that it appears to be a very good measure of whether somebody was infected with the virus, meaning if you have the antibodies, it's likely you had the virus. The challenge with the antibody testing is we do not have clear research right now that suggests the presence of antibodies is the same as immunity, meaning that ideally, we would like to say if you have the antibodies, then you can no longer contract the infection. And that's actually not the case right now. We also know that in most of the large population studies done with antibody testing, maybe 4 or 5% of the population are showing antibodies. So the role of antibody testing is still emerging. Right now, it is really not routinely recommended in terms of determining whether somebody is susceptible to the disease, nor is it routinely recommended for diagnosis. It's best used as part of studies to determine, for example, the prevalence in a population. 4 or 5% of my population may have been infected with the disease. We know a lot will be emerging about antibody testing, but right now there's just not enough known to know how and when it will play a role in our management of our populations in the fall.
Thank you. There's a question here, kind of a travel and sort of a general question. So maybe I'll start with Catherine and then maybe move on to Dr. Chin. Should we be discouraging international students who do make it to campus from traveling back home during breaks? And then kind of related to that, should we be altering our calendars so that students don't have breaks during the fall and maybe that they're done around Thanksgiving?
Thank you, Robin. To the first question, I think that it would be a very fraught, challenging situation for international students to return home with the expectation of returning back to the United States. And we've already seen a lot of issues involving that in the last 2 months. And with the incredibly changeable nature of the coronavirus, it would be very ill-advised in most cases, unless it was for a family emergency, for international students to return home with the intent of returning back to the United States to continue study or research. And to your second question, our school, Montana State, oddly enough, just today got word that our semester for the fall has been altered. We're going to have in-person classes, and we're starting 2 weeks early, and we're finishing just before Thanksgiving. And they're doing this for a number of reasons, including fewer trips home. And as you all know, the CDC has been working on domestic travel advice and is hopefully going to be having more of that coming out publicly soon. But there's the question of returning home even domestically for Thanksgiving break and being at the same time as influenza is beginning potentially. So it's something that our university and a number of others are certainly considering. Jean, do you have any thoughts?
Sorry, I forgot to get myself off mute, and I was being brilliant all by myself in my kitchen.
Oh.
I think it's a great idea to limit traveling and finishing up early at Thanksgiving instead of leaving for Thanksgiving, going back, coming back to campus for a week, taking your exams and going back home for your winter break. I think Montana State is brilliant, Catherine. That's my 2 cents, and I'm going back on mute.
Thank you. Dr. Deichen, this question is for you. Talking about the student health service, if point of care testing is being done within student health services, what happens when there's a positive test? Is the exam room off limits? Can anybody be in that space? I seem to recall in the recommendations that there was some suggestion about setting up separate spaces on campus, but obviously not all schools can do that. Can you speak to this issue? Maybe describe what UCF is doing?
Sure, Robin. So the testing that we're doing here at UCF involves drive-through testing using nasopharyngeal swabs, and it's antigen-based testing. So it's offsite. It's not in the health center. We're all anticipating that there's going to be rapid point of care testing that's available. Abbott Lab has obviously developed such a system. They're still tweaking it and working on it, but there's a lot that's evolving. Certainly in the health center in general, as we engage with patient care, it's inevitable that we'll have students that have COVID. It's just the nature of the business that's going to happen. So as a healthcare center, we have to have plans what that would look like, both on the front end with personal protective equipment for the staff that might engage with someone like that, and what would we do with that space as far as decontamination or disinfection. Those are plans that I think our listeners should think through. They should talk to their environmental health and safety department on campus about practices that might be utilized. And that really goes for any environment that might be contaminated with the COVID virus. Working with your EH service is a good way to help resolve some of those situations.
Thank you. So it looks like we're really at the top of the hour and we're at the end of our time today. Like I said, there are a lot of questions we didn't get to. I'm really sorry about that. We will be back next Friday when we'll further explore the issues surrounding COVID-19 and housing. I know that there are a lot of questions about that. Please continue to share your ideas and questions and solutions in ACHA Connect. And thank you so much to all our presenters. In the meantime, stay safe and be well. Goodbye, everyone.